Well, hello, everybody. Let's see here. How do I get the better screens? What the, oh, that didn't work. Ah, there we go. Oh, it's on your end. Okay. Well, hello. Thanks for being with us, everyone. We are going to go ahead and get started because we're always short on time. And as new folks join, we can do our best to give them an opportunity to introduce themselves if that works out for us. So, just a brief intro on to clarify what we're doing here today. This is a Community Advisory Council meeting of the Central Oregon Health Council. And we scheduled this kind of special meeting with the dental care organization representatives because we had several patient stories, members of our CAC and others, patient stories come up in the past few months. And we all thought, you know, why don't we just go straight to the source and bring in the folks who are focused on providing these services and managing the dental care organizations, of which we have 3 in our region, I understand. And so thank you for being here with us. Those of you from the dental care, representing the dental care organizations, dental providers. And we're really looking forward to this conversation with you. With that, I will pass it over to Myra Benitez to read our land acknowledgement.
1 second, Brad.
Oh.
Kelly, let me share screen. Thank you.
Thanks, Michaela.
Are we ready? Yes, okay. So our land acknowledgement, we recognize and acknowledge the indigenous land on which we live, work, play, and grow. This is a land of the Warm Springs, Wasco, Northern Paiute, Tenino, Klamath, Molalla, and Yahuskin. We acknowledge them as the past, present, and future caretakers of this land. It is on their traditional land where we partner to improve the health and well-being of Central Oregonians. We aspire to be good guests, honoring the concept in the Warm Springs culture. This land is for you to know and live upon and pass on to the children.
Gracias, Myra.
You're welcome.
All right, and now I would like to invite Linda Johnson to, she's gonna drill down a little bit deeper than I did on the objectives and principles, the reasons why we're here, what we hope to accomplish.
I thought I was, oh, there's the guiding principles. Yes. Our organization created the guiding principles to guide our discussion today. And the guiding principles are treat all people with respect, dignity, and compassion, build trust through collaboration and partnership, ask questions to understand and learn, work together to create solutions and reach goals, and always expect unfinished business. Our objectives today are twofold. Our relational objective is having the opportunity for the Community Awareness Committee or Community CAC and the DCOs to cultivate a partnership with the shared goal of collaboration and generating solutions. And secondly, our outcome objective is to determine if the conversation produced an understanding of the barriers faced by consumers and if there will be ongoing discussion to communicate progress and potentially initiate policy reform.
Thank you, Linda. Are there any questions before we jump over to introductions related to those objectives? All right. We pass it over to Kelly, I believe, to help out with introductions.
Yeah, we are going to do introductions. If you could just give your name, your role, and your organization. We've got 32 people on today, so we're going to try to get through this as quickly as possible. So we're going to start with our CAC members today. Let's start with Brad and then Connor.
Everybody, Brad Porterfield, consumer representative, CAC chair. I also am the director for Latino Community Association.
Hey everyone, Connor Carlson here, CAC member, and I'm a part of the Family Resource Center of Central Oregon.
Next, Elizabeth, and then Ken.
Okay, I'm Elizabeth Schmidt. I'm a consumer representative for Central Oregon Health Council, and I'm she, her, hers. Thank you.
Hi, good afternoon, everybody. Ken Wilhelm. My pronouns are he, him. I'm a CAC member, a community representative, and if your screen is on, you can probably figure out that I'm with United Way.
Next, Mandy, and then Maida.
Hi everyone, I'm Mandy Seeley. I use she, they pronouns, and I am a CAC consumer rep.
Hi, everybody. My name is Maida Benitez. I am a CAC member, consumer rep, and part of the Family Resource Agency.
Let's do Stacy and then Teresa.
Hi, my name is Stacey Shaw. I'm a CAC member, consumer rep. Thank you.
I'm Teresa Olander. I'm a CAC member, community rep.
And Miranda.
Good afternoon, all. My name is Miranda Hill. Pronouns are she, her, and I'm a CAC member, and I'm from Klamath County Public Health.
All right, I believe that is all our CAC members for today. Next, let's move on. Oh, hi, Linda. I'm so sorry.
No problem. Linda Johnson, I'm vice chair of the Central Oregon Health Council, chair of the governance committee of the Health Council, and community representative to the Health Council.
There we go. And I'm actually now seeing that we have somebody on the phone, not quite sure who it is. Phone number ending in 9124. Okay, maybe we'll come back to that person. Yeah, let's move to our dental care organization representatives. Let's start with Advantage, Molly, and then Nikki.
Great, thank you for having us. My name is Molly Johnson, and I'm the Vice President of Plan Operations for Advantage Dental. And I'm responsible for overall plan performance. So member experience, provider experience, relationships with our CCO partners and the OHA.
Good afternoon, I'm Nikki Coe. I am the Regional Vice President with Advantage Dental, and I oversee the practices.
Welcome.
Thank you.
Next, let's go to Capital, Manu, and then Kristen.
Great. Thank you again for this opportunity. My name is Dr. Manu Chowdhury. I serve as president of Capital Dental Care, and just happy to be here. Thank you.
Good afternoon, everybody. I apologize for the no camera. My name is Kristen Soto. I'm the general manager for Capital Dental Care and our staff affiliated offices.
Okay, on to ODS, Amy, and then Nancy.
Hi, this is Nancy. I'm not sure, Amy, if you're having some problems with your computer, but this is Nancy Avery. I'm with ODS Community Dental. I oversee our panel provider network and our dental Medicaid operations.
Okay, we'll have to check back with Amy on there. Okay, let's move on to our Pacific Source representatives. Let's start with Kristen and then Kyle.
Hello, Kristen Tobias. I use she, her pronouns, and I am the Community Health Coordinator for Pacific Source.
Hello, everyone. I'm Kyle Ash, Dr. Kyle Ash. I'm the Dental Director for Pacific Source.
Trisha and then Buffy.
Hello, everyone. I'm Trisha Wilder. I use she, her, and hers pronouns, and I'm the director for Central Oregon for the CCO, and I partner with Kristen in this work.
Next, Heather and Jessica.
Hello, everyone. My name is Heather Simmons. I use she, her pronouns, and I administer the Medicaid dental benefit for Pacific Source. Nice to be with you today.
And, oh, sorry, go ahead.
Sorry, Kelly. Good afternoon. Jessica Wolfman, Appeals and Grievance Manager for Pacific Source.
Great. And then I see Sabrina.
Good afternoon, everyone. My name is Sabrina Coleman. I'm the Compliance Officer at Pacific Source.
Great. Okay, we're moving on to OHA.
I think we've missed Buffy. I don't think Buffy had an opportunity.
Oh, did she not go? Oh, sorry. Buffy, are you there? I know
Yes.
There you are.
Yeah, thank you, Tricia. Buffy Hurtado, I'm an enrolled member of the Confederated Tribes of Warm Springs, and I am the tribal liaison.
Okay, now on to OHA. Let's go with Kaz and then Rebecca.
Hi, Kaz Raffio, Dental Director, State of Oregon, OHA. It's nice to be here with everyone.
Good afternoon, everyone. Rebecca Donnell, pronouns she, her, hers. I'm an innovator agent with Oregon Health Authority serving Central Oregon. Happy to be here today. Thank you.
And Tanya.
Hi, everyone. Tanya Curiel. I am with OHA's Community Partner Outreach Program. I'm a Regional Outreach Coordinator serving Central Oregon. Thank you.
Okay, we are on to our Central Oregon Health Council staff. Let's start with Donna and then Michaela.
Good afternoon, everybody. My name is Donna Mills, and I serve as the Executive Director for Central Oregon Health Council, and my pronouns are she, her, and hers.
Hi, everyone. I'm Michaela Arsenault. I'm a project manager at the Central Oregon Health Council. I play the role as CAC coordinator with Gwen, and my pronouns are she, her, and hers.
Next, Gwen, and then Camille.
Hi, Gwen Jones, she, her, hers, also a CAC co-coordinator and partner with you all. Thanks for being here.
I am Camille Smith. I'm the admin at the Central Oregon Health Council.
And Renee.
Hi, everyone. Renee Worth. I am a project manager with the Central Oregon Health Council, and my pronouns are she, her, and hers.
And then I am Kelly Adams, Admin Services for the Health Council, she, her, hers. And I just want to double check that I was able to get everyone. Is Amy able to have audio?
Kelly, did we discover who's on that other phone line?
It's Amy.
Oh, okay.
Amy Lawrence.
And the phone, and she's not there anymore.
Yeah, this is Nancy. She's trying to connect back in. She did introduce herself, but I was not able to hear her, so she's going to reconnect.
Okay. Great. Well, our next order of business here is to break out into small breakout rooms. We'll be able to answer our question for the day, which was, if you had you were given a plane ticket, where would you go? Anywhere in the world. So just take some time to sort of get to know each other a little bit. You'll have about 10 minutes or so to do that. Just bear with me. I'm going to get these groups as we all came in here today. Hold on one moment.
All right, it looks like everyone's back. I'm going to share my screen. How'd it go in the small groups? Good? Good.
Yeah, now we need a vacation, Michaela. We're all ready now for a vacation.
Spring break next week for some. All right. So before we dive into our discussion today, I wanted to give you an overview of how we're segmenting our time together. So the first segment is a time to learn from one another and build a level of understanding of the barriers faced by the patients as well as the dental care organizations. Then we'll move into a structured Q&A where the CAC and the DCOs have an opportunity to ask each other questions. And then finally, the closing is a time for reflection on what was discussed and considerations for the future. To maximize our time together, we're sticking to a tight timeline laid out on the agenda. Gwen and I will facilitate, and please expect that we may need to interrupt to keep the meeting moving to cover all of our prioritized conversations. Also, please keep the focus on system issues and system level change, and be mindful of how you take up and give space during conversations. Please feel free to use the chat for questions and comments. We won't have time to get to everything in the chat. However, we will save the chat for future discussions. And as Linda mentioned earlier, please expect unfinished business. So transitioning now to learning about each other's experiences, we want to build a level of understanding of the challenges and barriers people who have OHP face when receiving dental and periodontal care in Central Oregon. We also want to understand how services are provided and the barriers that exist meeting patients' needs that may or may not be in the DCO's control without major policy or system level change. So to start, Mandy Seeley will share a summary of the barriers OHP CCO members are experiencing. Then each DCO will have a maximum of 5 minutes to respond and give an overview of providing services and barriers. Then the CAC will have a chance to provide an initial response before we transition to that structured Q&A. So Mandy, if you're ready, I invite you to share a summary of the barriers.
Sure. Thanks everyone for being here. Today, I'd like to share just the tip of the iceberg of some of the barriers that OHP members have faced when trying to access periodontal and dental care in Central Oregon. These barriers are not only an inconvenience to members, but also affect their overall financial, mental, and physical health. Here are the barriers from just a couple of patient stories. One, scheduling appointments has been difficult. There are long wait times for an available appointment, even with emergency situations, and the appointments were not scheduled long enough to complete the services necessary. Two, communication inconsistencies are happening at the time of services and while trying to make an appointment or get questions answered. There have been many times where there has been no response or a delayed response from dental providers. At times, Pacific Source has had to get involved just to get a call back. Another instance where communication could be improved is integrating patient knowledge between different departments and staff members. Each patient is unique and has different needs that providers should be aware of to ensure a successful appointment. 3, there is a lack of OHP periodontal services in Central Oregon. This means having to travel to Eugene or Portland for those services. This takes time and money and is stressful for members to make an appointment. They may miss work and other obligations or need to find childcare during inconvenient travel times. There are hotel, food, and gas costs involved, but the reimbursement program isn't enough to foot the entire bill, making members choose between their care and other necessities. And they may have to go back multiple times for treatment, assuming that the treatment is even covered. 4, dental services coverage for OHP members. Many basic items that would prevent future problems are not covered, but also unaffordable, such as crowns. There are unrealistic timelines for replacing dentures instead of based on need. OHP only allows a professional cleaning 1 time a year, even though the American Dental Association recommends it every 6 months. Periodontal cleanings are not covered even when suggested by a provider, which could lead to further gum disease of periodontitis, which could then lead to other health concerns such as diabetes, heart disease, stroke, and more. OHP would then have to pay to assist with those health issues, when preventative care could have slowed down or even put a stop to that degenerative process. For members able and willing to appeal their denial of services, that process adds stress to an already stressful situation, and there is no guarantee it will change anything, which could result in members giving up advocating for themselves. And lastly, it is simply not an option for most members to go to an out-of-network provider or to pay for these crucial services themselves. We recognize that Oregon's Medicare and Medicaid coverage are better than a lot of other states, but we believe that all OHP members should be able to access periodontal and dental services conveniently and confidently in Central Oregon. How can the dental care organizations help their patients overcome these barriers?
Thank you, Mandy. So dental care organizations, you have up to 5 minutes to respond and share. We'll go in order of Advantage Dental, ODS, and then Capital. So Advantage, you're welcome to share your screen.
Give me a second here. All right, can everybody see my screen? Sorry, it's taking me a minute.
There it is.
All right. Well, thank you for having us today. Mandy, thank you for spelling out the concerns. We're going to try to address some of these in our 3 slides here. But I wanted to start out and just give a general overview of our dental delivery system. So you can see, for those who are able to see on the screen at the top, is Advantage Dental Services. That is our DCO, our dental plan that is contracted with Pacific Source. And so we are responsible for providing and paying for covered dental services. And for purposes of establishing a dental home, we assign all of our members to a PCD, or a primary care dentist. And so you can see on the left-hand side here, Advantage Dental, that is our owned staff model practices. And then we also contract with what we have here is network PCD, so private dentists as well. In the Central Oregon region, we have 5 Advantage Dental practices, and we have 7 network PCDs that we work with. And our PCDs are really responsible for providing general dentistry and pediatric care to our members. In the middle here where it says specialists, we also have a network of specialty providers available to members who may require a higher level of care based on a referral from their PCD. Currently in Central Oregon, we are contracted with all dental specialty types except for periodontics. And I know that that's a focal point of the conversation here. Speaking, coming off of what Mandy had said, there is limited benefits under the current coverage package. And I think due to the benefit limitations, there's not many covered services that would be provided by a periodontist. And as a result, we've had a lot of difficulty contracting with periodontists in the region for that reason. I would like to note that, for our Advantage Dental practices, we actually recently hired a periodontist, and we'll be starting at the end of the month, a little bit outside of the Central Oregon region, but will be available for using Teledentistry for evaluations and treatment planning, and then for some on-site perio services based on patient needs. So that's one small exciting thing to be able to share. And then underneath you see community care, teledentistry, and medical dental integration. This is kind of our safety net to our bricks and mortar structure that we have laid out. So our community care team, this is a team of dental hygienists and dental assistants who really work in the field. So we serve schools in the Central Oregon region, providing basic preventive services. We also are at Head Start sites, WIC, and then we have some co-location, I think 5 or 6 co-locations in that area as well. And then I talked about teledentistry, and I know that telehealth has been talked about quite a bit, especially over the past 2 years, but teledentistry is really a modality of care that we're trying to use in a number of different ways. And one of those is trying to be able to triage emergencies and get people in timely. So I'll go to the next slide here, and I'm going to try to keep it to the 5 minutes. I just wanted to give, and I know this is a lot of text, it's really text heavy, but just an overview of the covered benefits currently provided under the Oregon Health Plan. Again, this is just really high level. I think that it's important to note that, you know, the frequency of services may vary based on age and other conditions like pregnancy, and that limitations apply to some of these benefits too. I also think, you know, it's important to note that it's, you know, CCOs and DCOs don't set the dental benefits. These are set by the state and the Health Evidence Review Commission. And that even though these services are covered, they also aren't necessarily always provided. So there are coverage rules that are written around the OHP dental benefits, and the rules are used to make coverage decisions. So a major theme, I think, that overrides all coverage decisions is whether the service is dentally appropriate. So just because a member or a dentist requests a service, it doesn't always mean that it's going to be approved. And if the coverage rule criteria is not met, the service will be formally denied, and then the member will give an appeal rights, which we kind of talked about, or Mandy spoke about a little bit. The other slide that I want to go through is just some of the barriers and opportunities. So workforce shortage, you know, I don't think this certainly doesn't forgive access to care issues that are being expressed, but I do want to note that it really is a barrier. There has been a national dental assistant shortage for a long time, and there's certainly a provider shortage, and we're seeing a lot of turnover in staff, both dental assistants and front desk as well. And some of that shortage certainly impacts access to care. We are trying to work with our provider network on, you know, if it's within our own practices, more attractive compensation packages, loan forgiveness programs, things like that, to be able to attract and retain staff. Lack of OHP providers is a big issue. OHP tends to have rather low reimbursement rates, which might not financially make sense for some providers. And so, and like we said, there's a provider shortage in general as well. So that's, you know, from Advantage, that's why we have our own practices to try to be able to provide coverage in areas where there hasn't always been a local option available. So, I have no-show rates in here. I think that this sometimes contributes to access issues as well. We tend to see about a 30% no-show rate. And, you know, there's a ton of barriers on the dental practice perspective. We know that there's a lot of barriers from all the members that we serve as well. But, you know, I think that sometimes there can be, it does contribute to access concerns. Sometimes it can prolong treatment completion, things like that. The limited benefit package we already talked about, and obviously COVID has been a challenge over the past 2 years, although we're starting to feel a little bit better coming out of that. Some opportunities from us is we've set up an internal dental assistant training program where we're really trying to, you know, because of the shortage, trying to train people internally to become dental assistants. We're actually, you know, making it a requirement that these folks actually also have a CHW certification to better help navigate our members to care. Teledentistry has been very helpful, our community care program. We're trying to work more closely with our providers to overcome some of these barriers to care that have been expressed by the CAC. And then one area for this year is really working on member engagement. And I think that this is a piece that we would really find a lot of value and feedback from members of the CAC on ways that we can better connect with our members, share information, things of that nature. So those are our 3 sides. I'm happy to take questions, but I want to be respectful of the time, and it probably went a little bit over.
Thank you, Molly. We're going to transition to ODS.
Okay, let me get my screen share here. And share. Okay, can everyone see my screen?
Yes.
Okay, perfect. So I just want to, this is just the introduction here. So I want to just piggyback off of what Molly said regarding the benefits, and in Central Oregon, we assign members to specific clinics, and we also have offices that we contract one-on-one with to see our Medicaid members. I'm focusing heavy on the periodontal services on my slides here, and because what I think really needs to happen here is some of the contributing factors to periodontal disease. Some of it's genetic, diet, comorbidity, home care, medication, dental history or lack thereof dental history, trauma, therefore avoiding going to the dentist, and then sometimes the referral to a periodontist isn't explained to the member. And so with all these things put into place, and we have worked hours at ODS here trying to come up with what we can do to help our members and our providers, both our specialists and our general dentists alike. And we have a program that we put into place where the provider sends the referral to ODS, to our team, and we then turn around and send the member a packet of information regarding perio, because it puts the member in the driver's seat as far as their care, and we invite the member to call our team, and that way we can explain the benefits to them, and they can decide whether or not this is a route they want to go based on those benefits. Just getting a consultation sometimes is just the best thing they can do in order just to learn, because some of these things may be home care, it could be diet, it could be things that they can change themselves on a day-to-day basis that can help. So we found some great success with this program, and but we also need to help. We need our CCO coordination partners to help us as well, because some of the issues that we're finding from our members that they're saying they're having are really behavioral health conditions, medications, and a lot of medications cause a lot of oral issues. And so we need to get those PCPs involved. So really it's a collaborative issue for a lot of the perio that we have. We recognize that there's a lack of perio providers in the service area, and we are always recruiting and trying to recruit, and that's perio just has a small number of providers in general. So that's why we're working to really work closely with our members and our referring providers, and our CCO partner to help identify when when a member needs assistance. And then lastly, our providers, our specialists that we do utilize, they've really liked this process that we've put into place, because when the member does show up, they're not shocked about what's covered or what's not covered. They have, the periodontist has the materials that they send out. So if the member had any questions about it from a provider's perspective, they can help them with that. They've really supported our program, and it is it's just been an overall very good process, and we hope to continue doing this and make improvements, and share with our perio providers during our recruitment the process that we have in place, so it helps take the burden off of them, because unfortunately there is so little covered on perio, and that's but if we can help identify the perio issues prior to meeting the periodontist, a lot of that can resolve itself too, hopefully. So I could take any questions, or we can move on. What my closing one is. Oh, there we go. Oh yeah.
Thanks, Amy. We're going to transition over to Capital Dental, and we'll have time for questions in just a little bit. Manu.
Great. It's so interesting, for the last, ever since this was shared, this opportunity to meet, I think not a day went by where I was putting together information or thinking this through discussions with the team. But the way Mandy shared the real barriers, I kind of want to tell everyone a story that Kristen herself probably doesn't know this, even though she knows almost everything about me, is that in the 80s, my sister and I, or my family and I, we were on Medicaid for a few years. And, my mom had come from India, and she'd only been in the US for a few years. And at that time, my dad wasn't around, and I'd gotten a splinter in my foot. And we didn't know how to access services. We didn't know how to do anything. So a group of the family friend aunties in the neighborhood, we call them aunties. They're basically the mothers of, the family friends, children and stuff. And they held me down, and because my foot had swelled up, right? And with the splinter that was there, and they had to take this out. And it was, I don't know, I probably was maybe 5 years old or something like that. And it was such a horrible, traumatic experience that probably led to my fear of needles. And then I became a dentist, and then I still have a fear of needles. I have a history of fainting with needles. That's how bad my fear of needles are. And then anytime I tell someone, they just laugh because I tell them I'm a dentist. But I do have a deck. I do have some slides I prepared, but I wanted to share this experience because the way Mandy shared the barriers that are faced is really what is kind of what I believe the vision of the Oregon Health Authority is, the vision of all the dental care organizations, including Capital Dental Care. And we're all committed to this idea and this concept that health is wealth, and that we really want to provide everything we can in our power, in our means, in our resources to do better and provide better. And even though along the way, the system itself, the way it's been designed for decades on end, unfortunately creates what I call structural violence. I know that violence word is really extreme, but the reality is that that's what it does. But I really fundamentally believe that with the leadership of the Oregon Health Authority and with all the DCOs and the vision of the CCOs, we're really about trying to change that as well as we can. And then especially from a clinical perspective, as long as we're well supported with what we call evidence-based dentistry or evidence-based health to do the right thing. So let me go ahead and share my slides, and I'll just try to go through them a little bit, probably a little bit faster than I intended because I just wanted to share my story. So let me just try to take it from here. So anyhow, now I'm gonna have to figure out what I'm gonna say because I kind of messed up my own dialogue of speech of what I was trying to say. But essentially, gum disease is bad. It's an infection and it's inflammation. There's a lot of social determinants that like houselessness, smoker, diet, lifestyle that make gum disease worse. And then the reality is that it really depends on genetically what we're predisposed to. And so that's why we sometimes see 90-year-olds with all their teeth, and yet at the same time, sometimes like in one of my experiences, I had to extract all the teeth out of a 16-year-old because she drank 2 liters of Coke every day for a few years, and that just destroyed her mouth. And so the understanding of how long treatment time takes varies, and largely over the last few years as different scientific organizations have supported that it's more of an inflammation infection related process. It doesn't really necessarily mean that we need to sit there and scale the root surfaces as much. System challenges, I thought Molly and Nancy provided a really good idea of the challenges within the system. As I kind of shared from my own personal experiences, the system itself isn't, it requires improvement. And that's what we're all doing in order to achieve. But essentially the last few years have been really challenged with compassion fatigue around the Medicaid providers and the team members that support the Medicaid provider. And as a result of that, things have gotten very, very challenging to support a continued network. And as a result, Capital, as well as the other DCOs, had to flex into different and alternative forms in order to ensure that we can continue to support the network and provide care appropriately. The COVID pandemic also brought increased costs to the PPE as well as the workforce. And then something else that kind of came up that I thought was really kind of good to know was that beyond periodontal procedures not necessarily being a covered benefit for periodontists per se, and even though in the Capital network through the general dental offices, there are a few periodontists that are in our network through our staff affiliated offices. But it's interesting to note that an additional permit, sorry. Am I up on time? I took too much time, didn't I? I'm so sorry. Let me just get to my next slide real quick. I just really would like to say that, Capital is very, I joined in mid of June 2020. And even before that, Capital has always been very sincere about deliberately trying to improve oral health access and just kind of doing it in a different way. And so within Central Oregon, we have added a few different offices, General Dental Redmond and General Dental Madras. And we've also looked at co-location with community health workers in order to really have the member and meet the member at the level that where they are. Because that's so challenging to have at that moment. So I'm so sorry I didn't close very well, but I took too much time. Sorry about that. Thank you.
Thank you, Manu. All right, CAC members, would you like to give kind of a brief initial reactions to what was shared with you before we move on to Q&A? Any initial thoughts?
I would just like to say that I appreciate that the social determinants of health were recognized in people's presentations and trauma-informed training. It looked like in the last slide for people who are maybe experiencing some issues with being able to do self-care.
Thanks, Stacy. Other CAC members?
This is Linda. I really appreciated the sorting out of the different issues that the dental providers face. Some I'm not sure we'll be able to resolve today, like staff shortages as a result of COVID. But it helps to start to understand some of the complicated challenges that are faced on the other side.
Thanks, Linda. Elizabeth, Maida, Mandy, Teresa.
One of the things that I thought was that all DCOs operated the same. I thought all of those DCOs were under Pacific Source and they were just subdivided based on number of patients that they have. One like ODS got overloaded and so it expanded to another one in this area. But it seems like they don't operate exactly or the same. I kind of saw them in my mind as just spread like 3 different hubs of dental care under specific source. And I'm surprised that they operate so differently.
Elizabeth, you turned on your camera.
I just don't have any comments. But thank you.
Yeah. And feel free to engage in the chat as well. All right, well, thank you, CAC and DCOs, for being vulnerable and providing great insights. We're going to transition now to the Q&A section with Gwen.
Yeah. So I think you all have started to hear some of you demonstrate really shared understanding around a lot of the contributing factors that go to dental health. And I think we're, as Michaela and you all demonstrated, learning at a little bit more intimate level around the reality of providing services and the reality of receiving services and all the things that get in the way from looking at it from the system level. And so the CAC had a number of questions that they've been wrestling with that they wanted to ask and get a little bit more detailed information from the DCOs. And so the way this segment is set up is we'll kind of take turns asking and answering questions. So in just a minute, Miranda is going to offer up the first question to the DCOs, and the DCOs will have a combined time of about 10 minutes to respond. Folks are welcome to use the chat. And then DCOs will respond, and then DCOs, you'll have an opportunity to ask a question to the CAC. This is a great opportunity to learn directly from patients and people you serve. And so there'll be an opportunity for one combined question from the DCOs. So feel free if you want to put those in the chat. I imagine that DCOs may have a variety of questions that align with each other. We can pull out one or two of those that the DCOs commonly want to ask. If that occurs, then we'll ask that. And then CAC will have an opportunity to respond. And then as time allows, we'll do one more cycle of CAC asking a question. So that's kind of what to expect. So with that, Miranda, I invite you to ask away.
Great. All right. Well, hello everyone again. So our first question is, why do OHP members have such difficulty being referred and receiving periodontal care in Central Oregon? So I'll read that again, because if you're like me, I like to hear it a couple times. So why do OHP members have such difficulty being referred to and receiving periodontal care in Central Oregon?
So let's, what I'd like to do is we can just kind of go in the same order, and I'd open it up to Advantage and then ODS and then Capital to answer, and feel free to say pass or add on to what somebody else has already said. So.
Yeah, I'm happy to start for Advantage if you're still going in that same cadence. I would say that, again, and we talked about this a little bit before, but there is, with the limited benefits that would be applicable to a periodontist, I think that is definitely one reason that we're seeing that. Just speaking for Advantage, we have not had a lot of success. We have tried to contract with every periodontist in Central Oregon, and they are not interested in contracting with us. So when we do have a member who has, needs to be able to get into a periodontist, there is only one local periodontist who will even accept our referrals. And that's out of network, paying their full fees. So, that's why at times, Mandy, I know that you talked about going out of area. I think that has been, one reason for that is just for, trying to get somebody in. We want to make sure that folks are getting their needs taken care of as soon as possible. And sometimes the option, unfortunately, is to be out of area sometimes.
Thanks, Molly. Someone from ODS, do you like to?
Yes, this is Amy. Yes, this is Amy. Just mimicking what Molly said, if there are a lack of providers willing to contract, and some of that has to do with the fact that there are such little benefits that a periodontist doesn't feel as if they could really serve the member as far as fulfilling all their needs. And it becomes an out-of-pocket expense for the member because these are non-covered services that they may need. And so when a referral is obtained, sometimes the referral confuses the specialist, and it confuses the member because some people identify a referral as a guarantee of services, and it's not. It's basically an introduction from one office or to another. And so that's, again, going back to the program that we have implemented, is going to help with some of those confusions. So if anybody knows of a periodontist that wants to accept the Oregon Health Plan, please, by all means, share that name with all of us, and I guarantee we will all call them and offer a contract. So but those are the barriers that the DCOs are hitting those same barriers as far as, members not getting care. We're not being able to obtain those providers. So it's a systemic, in a sense, issue.
Thanks, Amy. Manu, would you like to offer? And then I'm going to offer this question up about the limited benefits, because I know that kind of comes from the OHA level. So I'm just going to cue that up as well as the continuation. But Manu, would you like to offer anything additional?
I just kind of taking it a little bit from a sciencey perspective. When someone is diagnosed with gum disease, there is what we call non-surgical therapy that is usually performed first, and that's what everyone knows as a deep cleaning. And so a deep cleaning based on procedures that are covered are performed by a general dentist and by a dental hygienist. Anything that is currently, and then the other form of therapy is surgical therapy. And surgical therapy, which essentially is what a periodontist would perform, is not a covered benefit on the plan as it currently exists right now. And it's kind of unfortunate because there's a lot of individuals that can have better health with having that as a covered benefit. But there's something else that I wanted to share with everyone. And the last time I pulled this was about 6 months ago, so I'm not sure how accurate it is right now. But in the state of Oregon, there are only 35 periodontists. Let that sink in a little bit. There's 4.2 million people that live in the state of Oregon, and there's only 35 periodontists, right? I mean, that is just phenomenally crazy if you think about what that ratio is. And on top of that, when everyone already understands that whole concept of supply and demand, last week I was in Central Oregon and I went door to door with periodontists to kind of ask them point blank, would they be interested? And everything that Molly shared is entirely true. Not only do they ask full fees, I've some asked for me, 20% over full fees, right? And then how do we manage the care that we have for all Medicaid beneficiaries to provide that level of care when that money can go for a child that needs to go to the hospital for care, or a special needs adult that needs to go into the hospital for care as well. So, the pot of money is limited. And that's the unfortunate reality of what we're working with. And we can only work within the parameters based on the Medicaid guidelines. And that's where we are. I just wanted to share that. Thank you very much.
Thanks, Manu. That's striking numbers. Yeah. Wanted to offer up from somebody from OHA, perhaps Kaz or someone else. Okay, thanks.
Yeah, happy to chip in the comment section, if you will. Thank you so much, Dr. Chaudhry and Molly. I think Molly did a great job of sort of encapsulating the parameters and the problem. Somebody in the chat, I believe, asked the reimbursement rates for OHP rates versus commercial. They are about 33-35% range of commercial rates. A couple other things that I wanted to highlight and dovetail into the points already brought up. Even in private practice, in commercial rates, in commercial payers, folks who have regular insurance out there, a referral to a specialist doesn't necessarily indicate availability of that service under that individual's plan. It is not uncommon for folks to show up at the specialist and then they call back the general dentist, Kaz himself, and ask them, well, why did you refer me if it's not covered? It didn't mean you didn't need it. It's just the way this insurance plan, be it OHP or Delta Dental or Blue Cross and Blue Shield, this is how the plan is spelled out. So that there right there is somewhat of a disconnect. And I think there's always room for improvement in making sure that particular point is articulated. The other thing that Dr. Chaudhry spoke of are limitations in both resources and budgets. Very few specialists available, huge population, and given the alternatives, if you will, in the marketplace, you know, a practitioner will choose to take on someone who will pay full fees, whatever those fees are, versus 33% of those fees, you know, 33 cents on a dollar. And lastly, where the guidelines around HERC, Health Evidence Review Commission, actually sets the guidelines of what is covered and what is not, and if it's scientifically and budgetarily supported. I know this doesn't answer the question, but this framing it, if you will, is significant and important. So I hope that adds a little bit to the conversation. Thanks, Gwen.
Absolutely. We have a couple minutes left on this question. Are there any related questions to this that CAC would follow up, or any other points around system barriers, around difficulty being referred and receiving care around periodontists that either CAC or DCOs would like to offer up?
Go ahead.
I have a couple of, I see Myra unmuted, Brad and Stacy. So let's do that order if you would.
Okay. So I know that you guys mentioned, you know, the big, huge population in Oregon and the, you know, very limited number of periodontists available for services. So I understand that part, but, you know, kind of like Linda had already touched on a point, how much lower are OHP reimbursements than other insurance and contracts? Like, you know, are they not wanting to contract with Oregon Health Plan because the limited benefits are so much lower, and how much lower are they than if we were to have private insurance? I luckily have private insurance through my work, but my husband and kids don't. And so I can see how I'm able to access services a lot quicker with dental, and I do have periodontal issues, than with my husband and kids. Like my husband is still on a wait list, right? And I've already been able to access these services, and I see there's a huge change. So how much difference is that the reimbursement rate?
I'm happy to reiterate, it's at around 33 to 35% of commercial rate.
And sorry that I'm going to continue this question.
No, please.
So with me already being able to access these services, right, and I'm being taken care of, I more than likely won't have to continue with dental follow-up. But my husband, who hasn't been taken care of, is going to continue his health, or, you know, dental is going to continue to deteriorate. And so therefore, I feel like he's going to be using a lot more, you know, services, and it's going to cost a lot more in the long run than if we were able to get patients like him taken care of immediately, so that the health doesn't deteriorate and they're not using a lot more, you know, services, resources in the long run. Because at this point, you know, he's already losing teeth. So, and, you know, that's another service that really isn't covered through Oregon Health Plan, where there's, you know, implants. And so, I mean, like if they were able to provide a little bit of assistance, we probably wouldn't be where we're at now.
Thanks, Myra. We have a couple minutes, Brad and then Stacy.
Stacy, why don't you go first?
Thanks, Brad.
I was just going to say that, Myra, that was similar to what I was going to ask. So, yeah.
Yeah, I don't know what part of the conversation, maybe it'll be in the Q&A, but yeah, this leads to all kinds of thoughts. Well, one is has there ever been, and I apologize for kind of trying to jump into a solution, but it's also a question that it might already exist, but is there, because yeah, it seems crazy for a dentist, you know, running a business, it is a business, a private dentist, you know, to take 35% payment for a service that they, you know, that I assume costs more than that to deliver. I mean, there's profit in there too, but are there any tax breaks or anything set up like in that sense to give dentists a tax break for providing OHP services? because they're taking a loss in a sense. Seems like the system needs to kind of give them back something to make it work, to increase access and increase the number of providers that will do these services.
Brad, I'm not sure if that was pointed to me, but I'll just jump in. If you know anybody in the legislature who can work that up, I believe our colleagues and friends on the delivery side would love to partake in that tax break, because the weight of a resource intensive service like periodontal care is very, very heavy on the delivery side that are already battling staff shortages, provider shortages. And so if you can get someone to cut them a little bit of a break and backfill, if you will, the gap, I'll cheer you on. I'm all about solutions too. It's not just about highlighting the problems. So.
Thank you, everyone. Mandy, do you want to pose your question? I just saw your hand raised up in the participants for just our last minute.
Yes. So mine is kind of a two-parter. I really appreciate that all of the providers are trying to get more periodontal providers. However, it seems kind of, I don't want to say useless, but if these services aren't there for these providers to, actually handle the issues, then basically we're having more providers just to get more assessments because we can't get the care. One is, how can those of us who are willing advocate at the state level to get these benefits expanded? And the other one is just a shout out to the periodontist in Eugene that I went and saw. He's a great provider, and we talked about these barriers, and he really reiterated a lot of the things that you all are saying about why providers are not on board. But another thing that I wanted to bring up that he mentioned is that he used to be a provider that traveled around the state, and a few years ago he was told that his services were no longer needed. So I don't know what happened there, but there may be ways to look into that and see what happened. Maybe the care just changed or increased over the years. But that's all I wanted to share.
Thank you, Mandy. I appreciate that. So this may be a segue. I wanted to give the DCOs an opportunity to ask some questions back to the CAC, and it may be around things that they've heard already about the system barriers. It may be around what CAC is open and willing to consider to support addressing some of these barriers, whatever it may be. But I'm looking for something from the DCOs that they would like to ask CAC.
I have a question, but Gwen, are you going in the order of Advantage, ODS, Capital, or should I just ask my question?
Go ahead, and then we can open it up the way it kind of worked last time. Flying by the seat of our pants a little bit here. Trying to make the most use of time.
Okay, so I did want to comment on a few of the questions that Myra, Miranda, and Mandy brought up. And, I fundamentally believe that the current system is in the process of being disrupted and innovated on. At Capital, we strongly believe in an alternative workforce model. In Madras, for example, we position an expanded practice dental hygienist to be at the center of the primary care dental home instead of the dentist. And that really opens up doors for more comprehensive related treatment. Then EPDH, as an advanced hygienist, is able to diagnose periodontal disease and treat periodontal disease at the time of the exam appointment. And so instead of essentially the dentist performing the exam and then scheduling out 2-3 months, whatever, a month later for the periodontal treatment, it's being done on the same day of service. And this model is the first in the nation. We opened it up back in July of 2021, and it's had success on what I call a double bottom line, which is, yeah, it gets the business stuff in order to make sure we can keep doors open, but at the same time, it actually improves quality, and that's kind of what it's intended to do. And so we have through the staff affiliated offices, we've actually started opening up this model of care into other areas in order to look at improving access for comprehensive treatment, comprehensive exams, and performing the hygiene visit, which is a periodontal therapy, at the point of care of the comprehensive exam, as opposed to being rescheduled. The question that I did want to ask is that, and I know this might be a silly question, but I fundamentally believe that in order to have this type of meeting where the CAC has partnered with the Central Oregon Health Council and engaged with the DCOs, there likely have been at least 100 to 1,000 times other members who've thought this one thing is like, how do I work through the system and really understand where do I go from here? And so the question that I have is that where we are right now and sharing the info, what the DCOs have shared, what Dr. Rafia from the Oregon Health Authority has shared, how can we communicate better so that all members can have more awareness, more information, so that they know how to navigate the system appropriately, not only from the science perspective, but then also from, just kind of work, really understanding and being able to get connected for that right care at the right time. Sorry for the long question. Thank you.
I'll open it up to CAC response.
I can have a response to that.
Thank you.
I really think that integrating and involving a lot of different organizations and the community in general is really important for overall health of our community members. And I generally say this a lot, but what about involving the local colleges and more public health announcements, more public health awareness, especially dental? I feel like being a part of the public health society now with my schooling, I don't hear a lot about dental, and I think it's really important. So I think just what if to help, since we only have 35 periodontal dentists in Oregon, trying to, while working on that, more preventative, more solutions for people who are going through social determinants and disparities and things like that. That's just kind of, I guess, my question is, could that be a helpful solution, and is it possible?
Linda.
I'm really intrigued by this great question about what can we do so that people are better informed about how to navigate the system. It's not unique to dental care. We had a patient story from last month that was about respiratory care, and that if people understand how to navigate the system or how to ask the right questions to get to the services that they need, or know how to advocate for themselves if the system's not working for them, and how to do that effectively. Hearing that that's coming from both realms, I think points to an area that the Health Council and OHA and Pacific Source might want to put some time and attention into.
Thanks, Linda. Other CAC responses?
I have a quick question to kind of clarify in my mind how, so with dental, is Pacific Source not a resource, or is Pacific, because there's the DCO, CCO, is Pacific Source still like your staff that is there to kind of help people navigate the system, answer these questions? Are they there for dental service as well, or not? And do the DCOs have the same thing? Do the DCOs have like patient navigator, coordinators, people to help if the OHP member calls, help answer these kinds of questions, help them navigate the system.
I'm happy to answer that. So Brad, Pacific Source is here to help navigate with dental concerns. We have a customer service department. We have a case management team that can help our members. Our appeals and grievance teams often help our members navigate. So we're doing that on a regular basis. DCOs are really needed when it gets to a little deeper level on navigating around getting to different providers, or when there's treatment related questions, things like that, because we don't have necessarily the view into those chart records that the DCOs do, and they're really active in coordinating the care on that. But we're both really active, collaborating with each other, sometimes on slightly different things. But to answer your question, yes, Pacific Source is really important now.
So I'm not sure about this, but maybe others can respond. But I'm guessing that it doesn't come automatic to consumers, OHP members, to call Pacific Source for a dental issue. I might be wrong, but that's just something I wanted to put on the table. The other thing is, the other thing I forgot. If it comes back to me, I'll speak up.
So it's facilitate. Go ahead, Molly, and then I'll jump in.
Oh, sorry. I was just going to say, so Dr. Chaudhry did a great job with phrasing the question, because that was going to be really my question too, is how can we better help members navigate care? On my slides, my last thing on there was member engagement, and I think that kind of speaks to this as well. One thing that we do as a plan is anytime somebody is enrolled with Advantage as a DCO, we send them a new member welcome letter that outlines a couple of things, who their primary care dentist is, how to seek care for emergency services. There's a couple of different things in there. And I just wonder for, in general, is there any communication, once somebody becomes enrolled with a plan, and then ongoing too, that we can best relay information, because all the DCOs are unique. I think we all have the same, basic benefit package and things like that, but we are each a little bit nuanced as well. So I just wonder, from that touch point, when somebody is enrolled with one of our dental plans, how can we give the information up front to be able to set that member up for success in navigating the system?
I wanted to say something. If we wanted to change something with OHA, how would we go about that? Is that legal? Is that national? I mean, who dictates the coverage on dental if we wanted to change it?
Great question, Elizabeth.
Okay.
So Elizabeth, the part of OHA that determines dental benefit coverage is called the Health Evidence Review Commission. The acronym that people often refer to it by is the HERC, HERC. I put some information and a link to the HERC website in the chat. But that is where decisions are made around benefit coverage. There's a panel of providers, medical providers, dental providers that review evidence around the effectiveness of various treatments and decide what is included in the Oregon Health Plan benefits package, both for medical, behavioral health, and dental services. And so if people are interested in what is covered and how to influence what is covered, that is the place that folks should be providing feedback to. And I can put more information about what email address to use to provide feedback to the HERC, the Health Evidence Review Committee, in the chat.
I think what we need is to improve the percentage of payment, because that's the whole issue. I mean, if we're only going to give someone a third of the professional rate, well, of course they're not going to take it. Can't we get that increased? Would it be to her? I don't.
So
Right. Yeah.
The Health Evidence Review Committee actually doesn't determine what percentage of OHP is allocated towards dental. That they just make benefit decisions based on clinical evidence. If you're wanting to advocate for changes in terms of reimbursement rates for dental, Kaz, I'm going to refer to you to say what is the best place that a consumer would go and advocate at OHA or with their state representatives to influence that.
I'd say reach out to me directly. I'm happy to direct you to the right people. And I'll put my contact information right in the chat.
Okay, because I would like to advocate for higher reimbursement. It seems that's the barrier. Our main barrier is the reimbursement rate. If that were improved, I think we'd have better coverage. So let's say even 50% would help. So that's my comment.
Thanks, Elizabeth. I want to put a bookmark there because I think where Elizabeth went to was kind of the system level change that the CAC is wanting to explore and converse. But I also want to take a moment to give an opportunity for folks to answer the question around educating folks. But I also want to honor that sometimes education, though it's good to understand and know the system, that in and of itself, having to be educated about the system is also a band-aid to a very complex system. And so the CAC provides regular feedback on education and information for public use. And the desire of this is to move beyond education to that. How do we push on the system to reduce the need for this level of education and make it easier to access and easier for providers to provide the care that they want to provide. So want to give CAC an opportunity to respond to Molly's original question of what are some ways that we can better provide information and better equip folks. And then we'll segue back to the system level question.
So I want to speak to that. One of the things that I'm aware of and access when I have the ability to do so, not necessarily in healthcare, but any specific issues, are advocates. So part of the education is making sure that Family Access Network advocates have this information, that there are, I had posed a question earlier when I believe it was ODS was mentioning that they had advocates on their team, whether Advantage Den did, and I also posed that to Capital, because advocates, they're there to advocate for the person with these issues, and they can also be a middleman, as it were, to if these members are not speaking up for themselves because they're just sick of fighting the system, if they reach out to the advocates, then the advocates have that information to bring back to the providers. So I think advocates are so important for any type of care or issue. And then educating, like having the education at the dental providers offices, making sure that the staff is educated on these things that are available to be able to relay. Because something that I learned today that was brought up is that there's not really a difference in a periodontal cleaning and a deep cleaning, which I was given an inaccurate information that I would need a cleaning specifically to a periodontist. So that opens up opportunities for my specific situation. So like I said.
And I can just address and I'm sorry, I haven't been monitoring the chat all that well. There's a lot going on over there. But in terms of the advocates, so we have for Advantage, we do have a care coordination team. It's an 8-person care coordination team, all of who are CHW certified, and really try to work with members and advocates to help navigate the system in a number of different ways. So it's not a sort of one size fits all approach. But I do think that team is, they will work really hard to do anything that they can to kind of break down barriers to care and work with members and, their guardians, if they're a child, or work with advocates that they've been working with the DHS system and other systems that our members are with. So, but I appreciate your comments, and I think that you make some really good points, especially about the lack of information, with respect to cleanings and things like that. So
I can just share in the practices, we utilize that team to help support the patients, and we'll, put in requests to help them navigate things and get the access and referrals and things that they need. And then we're working towards embedding those community health workers into our practices as well. As dental assistant patient navigators. So that's currently in the works, and something that we will have to have additional support and guidance and advocate for patients and get them, help with resources and direction for those things as well at the practice level.
So at Capital Dental, every DCO is kind of different. And what's a little bit different about Capital Dental is that we only have one plan, and that's the Medicaid plan. We don't have any other type of insurance plans that are a part of our system. And so I could share with you that on the member services teams that provide these types of care coordination, we have over 40 team members that are directly for and providing access to connecting members with appropriate services. In addition to that, we do also have a specific specialized care coordination team that takes care of other components and what I would probably call higher level referrals, where there's greater necessity for follow-up. And that's just generally how we have our hierarchical kind of structure kind of contained and stuff like that. I hope that answers your question. Sorry, were a lot of different questions, even in the chat, and I just want to make sure that I'm explaining and representing Capital appropriately with the questions that are being asked.
Thanks. So we have opportunity for just 5 or 6 more minutes for one more question from the CAC. So I want to take it back to that system level question. And Mandy, you and I have been chatting on the back end to kind of bring it back to system level before we close out and kind of find out what's next.
All right. What are some of the other possible ways to encourage the system to make changes? Example, what would talking to her need to look like, and what would going to the state need to look like?
This is maybe a totally crazy idea. It goes back to the last question we were talking about how do we educate patients to be their best advocates and how to navigate the system. That's a challenge, not just for OHP patients. I think it's a challenge for everyone. And I know that each plan has their own unique ways and people that they need to get to navigate the system. But there's also some common questions that are frequently asked that go regardless of what plan you're on. What about if we got each of the plan members together with OHP and Pacific Source and came up with a single point of access for the more general information that the CHWs could work with, that patient advocates in a particular office could work with, that any front level, even an individual like myself, could access to get the first level of information, and then have some if you want to advocate for this, here's the link to OHA, or whatever the appropriate links are for as your questions get more specific and pointed, or direct it to each of the plans, but give that basic set of information that fan advocates or others could use in one place that's easily distributable or easily accessible.
Thanks, Linda. Other responses or thoughts around other possible ways to encourage and support the system to make changes with regards through HERC or the state and funding?
I would just say, I know that it would take a lot because gathering information and getting information from patients can be really difficult, but being able to see what areas have the worst statistics, excuse me, for periodontal care, and being able to compare that to the cost of people who aren't able to access it against what it costs to essentially try to fix or put a Band-Aid over it, opposed to if they were able to access the care in the first place. If there was some kind of like 5-year plan of, okay, we're gonna do this, by year 2, we'd like to see so much public health announcements, and by year 3, we'd like to see those numbers drop. And then, I can't explain it really quickly, but basically, how can we try to fix the issue now while advocating for prevention later to essentially save money? Because that pool, that money comes from somewhere. It's taking from another service or vice versa.
Thanks, Stacy. Any thoughts from the DCOs? You all mentioned there was a comment early back around, incentives, and if we could find incentive funds to support DCOs, that would be great. We've talked about state funding, regulations. From your intimate experience with the decision makers, what support would you need at the decision-making level of the system, state system, to support and encourage some of these level of changes?
So I can start. I think that the HERC, obviously setting the dental benefits, I know that I'm not sure, I haven't been, we used to have our dental director sat on there, which was really good because it was an a dentist, very familiar with the OHP services and the OHP population. I think that having, additional dental representation that is very Oregon Health Plan minded would be a good step. And again, I'm not familiar with who's all on the HERC right now in terms of dental representation, but I think that is, a good step. I think just in terms of getting providers, we've talked about it, it's been the theme, I think, of this call, is appropriate representation, is appropriate reimbursement. So whatever we can do at a state level, I think that a lot of this, coming from members themselves and trying to advocate for that, as dental plans, we're always advocating for, increased dental benefits. And I think it was mentioned at the top of the call that in Oregon, we do have a pretty robust dental package, especially for adults. It's really not as great in most other states. Not to say that there's not always opportunity to do better. But typically those benefits, like the adult benefit package, when funds are limited, that does happen to be an area where funds might, or where benefits might be sort of on the chopping block when there is limited funding. So I think as long as there's awareness around that, sorry, that's not a really eloquent answer, but that's kind of what I have right now.
Thanks, Molly. Amy, and then Manu, anything you'd like to add to that?
Yeah, this is Amy. Benefits are, the money reimbursement is one aspect of it. And I think also just one more thing to touch on is also so we have provider responsibilities, right? We have DCO responsibilities, CCO responsibilities. There's also member responsibilities. And one of our biggest hurdles is missed appointments. So if we could somehow address that as well as something that might be potentially covered with with the HERC team, missed appointments reimbursement for that, because that is probably one of the biggest complaints that we get from our providers, second to reimbursement, because the majority of our providers that we have are already participating because they care about the community. But if they have a no-show, if they have patients scheduled and they don't show, that's productivity lost for everybody. And so I think that really should be addressed as, with the state, is some form of reimbursement for our missed appointments.
Thanks, Amy. Manu?
You know, I think Molly and Amy touched upon it quite well already. I think just to add a little bit more color around Amy's latest comment is that it is true that Medicaid members have social determinants of health that have become barriers relative to those who have commercial insurance. Right. I mean, even having access to a car is one really good example of that. Right. And, you know, if the car breaks down, or if you have to take a bus, if you have to take 4 buses, whatever the case might be, in order to have that access, it's quite challenging. And those are realities. At the same time, when a dental provider, whether it's a staff office or whether it's a panel provider, you could call it that, or an out-of-network provider, the show rates that we've seen for those who have commercial insurances are in the neighborhood of 95% and above. For those that unfortunately are chiefly OHP Medicaid, we see show rates between 60% to 75%. And so when already reimbursement is so low, and that time has been allocated, that chair's time has been allocated, let's say by an oral surgeon who's doing thousands of dollars of treatment to remove infection from a child or from an adult, that is lost productivity from that contracted provider. And so definitively, you know, that is a big factor for getting, you know, kind of enrolling other providers. And having said that, that's why, you know, there's been heavy investments, I believe, from all the dental care organizations around alternative workforce models, with community health workers engaging with members at the level, and Capital has done the same as well. We've been co-located already in a few offices, as well as through our mobile dentistry platforms as well. But I think that's all that I would like to, I know right now, to say to comment on what has been shared.
Thanks, Manu. Well, thank you, everyone. This kind of wraps up and ends us in that unfinished business space of our conversation. I'm going to hand it over to Brad for the last 15 minutes as we kind of do a little bit of a process reflection and some just more interpersonal reactions and feedback.
Yes, this has been, I think, fantastic. So thanks again to everybody who's here with us, CAC members, everybody. I think these things always tend to raise as many questions as they answer. So part of our, I think, question moving forward is what's next, and we'll kind of get to that, I think, through some poll questions. I'm not exactly sure what the poll questions are yet, but I think that's going to touch on that. Yeah, so let's go ahead and roll through these poll questions, and I want ask everybody, please stay with us and do this with us, because it's going to help us move forward. So Kelly, do you want to explain, if there is any explanation needed, the poll?
We're just looking for a little bit of feedback, how everyone felt about our conversation today. It is anonymous, so don't worry about your answers. And then if there's any more additional information, changes, suggestions, comments, concerns, recommendations, please feel free to add that to the chat. We're going to save all the information from the chat and sort of condense it down and distribute as needed. So we'll just take like a minute to get the poll questions going.
So it's the 3 questions.
Yep, just 3 questions. How
Okay.
valuable was this conversation? Would you like to continue to collaborate and problem solve on these issues? And would you be willing to meet again to continue this conversation?
Do we still have people on the phone?
We do have a couple people on the phone. Unfortunately, the poll's not going to be able to go to them.
I don't know if there's any way if they're willing, they could just respond verbally.
Yeah.
I hate to exclude the people on the phone, but that's up to you. Those of you on the phone.
It came, this is Amy. I'm on the phone. It came to me. I submitted my.
Oh, okay.
You're good.
It looks like pretty much everyone has answered. So I'm going to end the poll and then share the results. So how valuable was this conversation? 43% said extremely valuable. 26% said very valuable. 30% somewhat valuable. And no one said not very or not at all. So that's a good thing. Second question, would you like to continue to collaborate and problem solve on these issues? 78% said yes, 4% no, and 17% not sure. And our last question, would you be willing to meet again to continue this conversation? 87% yes, 4% no, 9% not sure.
Okay. So the vast majority of us are willing to continue the conversation and working on these issues. That's fantastic, and I'm glad nobody feels like they wasted their time based on that first question. It's always important. I think we have 10 minutes or maybe 9 once the 10th minute clicks to 9. But I'd like to just open it up and see if there's anything anybody's just feeling that you want to, within a minute. Sorry about that. Just give space to everybody, but within a minute, if there's something you want to share just about your overall sense of spending this time together. And just feel free to unmute.
I had a question. So next term, I'll be working with Deschutes County and Crook County on issues in the community that don't have to do with dental, but they do have to do with mental health and physical health. Are there grants that federal or state offer that can help, maybe more public health announcements or education to college students to like help with these issues with navigating the system for dental? I just was curious.
Is there anybody on this call that has Kaz?
Yeah, I was just going to say I'm happy to look into it for you, Stacy. Behavioral health is exceptionally well funded, and that might be the back door to look into possibility of finding and locating grants.
Yeah, Stacy, I was going to offer this. Sorry, I was going to offer the same thing. I'll put my contact information in the chat. Between Kaz and I at OHA, we should be able to look into this for you and see what might be available.
Okay, I was just curious because my professor and my advisor does a lot of outreach to the universities and such like that, and we partner with them and we take on a lot of projects like this, but not for dental, but for mental and physical health. And it just seems like something that is really missed out on, and I just don't know if there is a way to integrate. OSU is a public health college. Is there a way to get more support from local colleges and universities?
Rebecca's shaking her head. Yeah.
Great idea. Great idea. And I can talk to my advisor and see what her thoughts are and see if that would be something that she would be interested in maybe looking at as well, if that makes sense.
Anybody else who, thanks, Stacy, thank you. And those who responded. Does anybody else just want to share how you're feeling about our time together? And
Well, I just want to share, say I appreciate people's candor. These are somewhat delicate conversations, and I think there was a maximum degree of transparency and a minimum degree of defensiveness. So I appreciate that.
thanks, Ken. Who else?
This is Tanya. I just have an initial thought that it seemed like there was some interest, at least on something that could be done immediately, of offering some training for community health workers and others who are out in the community. I know that I partnered with the dental plans a while ago to create some training for our OHP assisters on how to navigate the OHP dental system. So personally, I'd be interested in continuing that and potentially expanding it to others so that there could be like cohesive collaborative training offered that could support our community in navigating the system better.
Thanks, Tanya. Sounds like a good idea to me. Who else? Any other CAC members? And this is just general, how you're feeling about our time together today. General comments.
I just wanted to thank everyone who participated today. I get the real strong sense of a desire and a willingness to solve this problem and make the system better for everyone. And from that place, I think we can build towards some solutions that hopefully will change the system. I understand and I feel the commitment from everyone. And I just want to say thank you for that.
Thanks, Linda. Anybody else? This isn't limited to CAC members.
One last shout out to the DCOs for their willingness to join us and prepare so well for today. I really appreciated the entire conversation. I think there's lots of great next steps here and really great questions asked in this space. So kudos to you all.
Thanks, Tricia. Anybody else? We actually have this time. It's kind of amazing. And I like pushed up against the clock for once. So good job, everybody, on managing the time and managing your time speaking. I want to make sure anybody who wants to share anything, any of your, how you're feeling, if you have questions or comments about where we go from here. All right, then we will give everybody a few minutes of time back to you. So thank you once again. I think it's been very productive. Of course, the challenge is always, you know, what do we do next? But you know, the CAC, we meet monthly and we can continue these conversations, and hopefully everybody, DCOs and Pacific Source and Oregon Health Authority, everybody here. I think even Elaine popped in from Mosaic. You know, you will also have steps that you'll take from here and you'll communicate those to us. We'll do our best to communicate to you what we do next. And just keep the conversation, the communication going. We really appreciate it.
Thanks, everybody.
Thank you.
Thank you so much.
Thank you.